Good morning, everyone. It just turned 8 o'clock. As you join, please chat your name and location into the chat field to record your attendance. I'm going to introduce, I'm remote this morning, Shannon Switkowski, the clinic coordinator. Rick, do you want to start at the hub team?
Sure. I'm Rick Cronacci. I'm the web content producer for Cardi-OH.
Jim Warner, Case Western Reserve University behaviorist.
I'm Goutham Rao. I'm the director of the ECHO program at Case Western.
Jackson Wright, Case Western Reserve Professor of Medicine Emeritus, and co-lead of Team Best Practices for Cardi-OH.
Thank you. Dr. Rao, do you want to start?
Okay, thank you, Shannon, and thanks to everyone who's able to join us this morning. I know there's been a lot of disruptions with school and work recently, so I appreciate the effort. This is the structure of the clinics. I don't need to go through this in any detail. And oops, next slide. You advance it, Rick? It's not. Okay, whoops. I want to go back one. And these are the disclosures for this morning. I don't have any disclosures this morning of relevance. So we're here to talk this morning just for one brief session about children and adolescents. I'll tell you how I got interested in this. So in 2000, I'm a family physician by training, but much of my career has been spent in the Department of Pediatrics at the University of Pittsburgh and at Children's Hospital Pittsburgh. And I was the director of the pediatric obesity clinic there between 2004 and 2011. In 2004, we had lots of students and residents and fellows who would come through. And I don't remember who this young man was, whether he was a resident or student. He said, I'm looking for a research project. Can you give me something to do? This is always a challenge. So I said, why don't you go do some chart reviews in primary care and focus on blood pressure? So he went to our residency clinic. About 90% of the patients there are African-American, most of them from the area surrounding the hospital. And he started to do some chart reviews. And he didn't do very many, of course, because he had limited time. But he found one patient that I thought was very interesting. He was a 13-year-old boy with asthma, and he'd come in with his asthma several times with his mother. And by all accounts, his asthma was superbly looked after. He got his flu shot, he got asthma education. I think whoever looked after him showed him how to use his puffers, take his medications, he checked his own peak flows. Very nice family, very, very well looked after. But his blood pressure averaged over 3 visits in 1 year, 180 over 110 millimeters of mercury. There wasn't a single note in the chart, besides the blood pressure, nothing like BP high, nothing like follow-up for hypertension, absolutely nothing in the chart. So I figured we were on to something at that point. So I want to start with that introduction to you. The other thing I would tell you is, even though there isn't something that magically happens when a child turns 18, that they suddenly need to have cholesterol and blood pressure screening and everything else. The precursors of heart disease start in childhood, probably as young as age 5. So keep that in mind as you consider this topic. So in the 25 minutes that I have, all I really want you to do is to sensitize you to the problem. There's no way we are going to cover the entire epidemiology or any of these in a lot of detail, but I'm going to present enough to you that hopefully you will start to take the problem seriously. And if that is achieved, I'll be thrilled. If you want, this is a 2016 state-of-the-art paper I wrote in pediatrics. We're going to come out with another one, probably in the next year or so, that you can look at. There are guidelines and that sort of thing, but this will give you a lot of useful information that you can read at your leisure. So I wrote the word imagine here, and that's probably an interesting slide. Imagine that you as an adult go to your physician's office, your provider's office, and you walk in and the medical assistant or the nurse obviously does not know how to take your blood pressure. She puts the cuff on the wrong way and she's not sure how to use it. She just really messes it up. And then she gets a number and you ask her, well, how's my blood pressure? And she says, I have no idea. Then you go into the physician comes to see you and he's reviewing your chart and you have some other problem and he looks at your blood pressure and you ask him or her, how is my blood pressure? And he goes, I don't know. I have really no idea. I'll have to look it up. And then you ask the physician or the provider, well, did you look it up? And he goes, yes. He says, it was high. Okay, so then you ask the physician, so what are we going to do about this? And he or she says, really, I really don't know what to do about it. That is the current state of management of child and adolescent hypertension in this country. So to give you a rough idea, the first guidelines on pediatric hypertension were published in 1977, so 43 years ago. And there's one line in these guidelines that says detection and management of hypertension in children and adolescents is the next major frontier. 1977, it was recommended that blood pressure be checked in all children ages 3 to 17 at least once a year. 40 plus years later, the vast majority of cases are missed. They're missed in Cleveland. David Kalber and his team showed that about 10 years ago. They're missed in Pittsburgh. I showed that about 6 or 7 years ago. And we did the study in Chicago. 3/4 of cases are missed there as well. So this is something extremely serious. Why do we bother? Well, first of all, I mentioned that atherosclerosis does not begin magically at age 18. It starts much earlier than that. Not only that, children and adolescents with high blood pressure experience target organ damage, not remotely, but actually in childhood. So we have a significant proportion of kids who, for example, have left ventricular hypertrophy in childhood from hypertension. Another important rationale is that secondary causes, and we don't need to get into a lot of detail about these, but these include classic things such as renal artery stenosis, for example. Those are more common in children, and there can sometimes be reversed. If you don't detect hypertension, if you don't make a diagnosis, the child cannot benefit from this treatment and suffers long-term consequences. The other thing that is unfamiliar to most pediatricians and to some others who care for children and adolescents is that there are a number of treatments that are approved and safe and effective and have been used for many, many years. So why do we miss this? There's a number of causes. First of all, sometimes we don't check blood pressure. So this was a passion of mine for a long time. There is a forum called the National Quality Forum. The National Quality Forum adopts quality measures nationwide that are then recommended by CMS, and CMS adopts them. I was the measure steward for screening blood pressure in children ages 3 to 17 at least annually. And it was adopted as a quality measure. I was up against fluoride varnish annually, and because you can't adopt everything, and I actually won out. So, but I actually believe very much in fluoride varnish as well for kids. So if any of your staff is cursing the need to take blood pressure in children, they can blame me for that. Interesting, the pushback from many people was very interesting. A lot of medical assistants and nurses have said, oh, we don't have time to take blood pressure in kids. We've got so many other things to do. But to me, that's like saying we don't have time to administer vaccines, or we don't have time to check cholesterol, we don't have time to check blood pressure in adults. It's part of your job, and so we have to find the time to do it. But so failure to screen has improved, but technique is generally bad, getting better. The complexity of interpretation of blood pressure in children is a big issue, which we'll come to in a moment. The other thing is the more you know about how to follow up and treat a problem, the more likely you are to make a diagnosis. So there's a well-described phenomenon. If you go to a CME conference on a specific topic, let's say I go to a CME conference on chronic kidney disease, and I spend a week talking about chronic kidney disease as a primary care physician, and I come back, I guarantee you more of my patients appropriately are going to be diagnosed with chronic kidney disease, and the management of that is going to be improved because I'm sensitized to it. So there's very little familiarity with this issue, and that's why the problem of the hypertension is missed. Performance in screening has been improved pretty significantly. I don't think this drop, this is around the time the National Quality Forum, we were trying to make this a quality measure. So this is the fact of the matter is most children do have their blood pressure measured annually. And prior to 2000, prior to 2008, 2009, that was not the case. So blood pressure is being taken. So at least we're doing well in that respect. Just because you take blood pressure doesn't mean the problem is solved, of course. Diagnostic standards are complex for a number of reasons. You cannot use a single number like our 140/90 or 130/80 as we do in adults, because children's blood pressure naturally increases as they get older. Taller children have higher blood pressure than shorter children. Boys have much higher blood pressure than girls, and that's just the physiology of it. So all blood pressure standards have to be adjusted for height, sex, and age, which means it becomes very complicated, and it's defined as the 95th percentile or higher. We tried many ways to encourage diagnosis based on this, including color-coded charts, et cetera. None of it actually worked. The only thing that seems to work is a dot phrase in the EPIC EHR called .BPFAL. So if you guys have EPIC, we do not at UH, but many of you do. That'll give you not only a child's blood pressure, but the 95th percentile standards, plus whether they're hypertensive or not. In 2017, new guidelines came out, and Dr. Kalber was one of the co-leaders of the guidelines that tried to simplify them. So the numbers to remember here are very useful. If a child has a blood pressure of 130/80 or higher, regardless of their age, they are hypertensive. You have to have them back on 2 additional visits and average them together. But if the average is 130/80 or higher, they are hypertensive. For children under 13, you still need to use the percentiles, which can be incorporated into clinical decision support. So I'm not going to get into too many of these standards beyond that. The bigger problem is not, are the standards simplified, because they have been, and we don't know what their impact has been because they've been out for less than, a little over 2 years. But the biggest challenge is measurement. I've been trying to measure blood pressure in kids for 16 years. I've given up trying to do it in the office. Every possible enticement, every workflow, tried everything. If you guys have any ideas, please let me know. If you don't see children as patients, it's hard to relate to, because it sure is easy to take blood pressure in adults, but it is tough. In theory, the NIH tells us the child should be relaxed, calm, and seated. Try doing that with a 4-year-old. Not easy at all. So here's a video clip, and Rick, I'm hoping we can play it. Okay, so this is Andrew. I was the principal investigator for a project called Improving Diagnosis of Hypertension in Children, which took place in FQHCs across Chicago. And Andrew in this video is 6 years old. He was our best candidate. He actually likes his blood pressure to be taken. He sticks his arm out and he sits extremely calmly. But we tried 20 kids, including one of my own, and it was very, very difficult to do this. So Andrew is the son of Kate Curley, who was a co-investigator on the project. And so I think he has a little bit of priming as far as pediatric hypertension goes. But I show this video clip because this is what a child should, how a child should be performed if he or she is having their blood pressure taken. And it's really, really uncommon. It's actually very, very tense and nervous for children, young children in particular. If it's an adolescent, it's not a problem, of course. But it's a little bit frightening. It doesn't feel normal to have your arms squeezed, etc. And there is no doubt that even a cooperative child is going to produce a reading that may not reflect their habitual blood pressure. I like that. Sit them in front of a Disney movie. Believe me, we have tried everything. Toys, sitting in front of a Disney movie. They're not supposed to talk either. So the guidelines, I will tell you overall, have not been very effective or useful. This is what the NHLBI guidelines on evaluation look like. And if I see something like this as a practicing physician, I tend to turn the page. And I don't want to get on a soapbox, but a lot of guidelines are assembled by people who don't necessarily see patients. But we do have some exceptions. But this is the original guideline. It's not really all that useful. And I will tell you that if you have a child who is hypertensive, there are certain key things that you want to do. And Lizzie, you might get any rationale for evaluation of hypertension, whether it's children and adults, falls into three categories. You're looking for target organ damage, you are looking for secondary causes of hypertension, and you're assessing other cardiovascular risks. So when we ask residents or students, okay, I want to get a specific laboratory investigation on this individual with hypertension, I often ask people, well, what is the rationale for it? And if they say urinalysis, and hopefully the student or resident will say something like, well, I'm looking for target organ damage. They might have proteinuria. That's what I'm looking, that's why I'm getting urinalysis. And some of them are very, very creative. And I said, well, you know, this young woman wanted to get a CBC. And I said, why? She goes, well, because they might have had chronic kidney disease leading to erythropoietin deficiency. And that's why I want to get the CBC. I said, okay, at least you're giving me a rationale for it. What should you do when you have a child who's hypertensive? Basically, you don't have to do a whole lot. Urinalysis is easy enough to do. EKG is no longer recommended unless you're putting them on medication. One of the most useful investigations we have found, especially in young kids, is the renal ultrasound. And so if you're going to do something, you don't need to get an echo, you don't need to get an EKG, but renal ultrasound is probably the most useful sort of thing. Some of you may know a little bit about likelihood functions. It's how often a positive finding occurs among people with that condition versus those without. So an abnormal renal ultrasound finding is 742 times more likely to occur among people with among children with secondary hypertension as those without secondary hypertension. Gives you an idea. What you are looking for, what you are looking for is, can you go back one time? Essentially is asymmetry of the kidneys. We won't get into any sort of detail. So the typical sort of thing you might see is, I'm pretty sure this kid is hypertensive. Whether they're obese or have other risk factors is another issue. And if you're going to get an investigation, get an ultrasound of the kidneys. If there's asymmetry of any kind, that's usually a good point to stop in terms of your evaluation and refer them to a pediatric nephrologist who can assess them for secondary hypertension beyond that. So that is my own soapbox about is evaluation. And of course, you know, I do run another curriculum on this topic, and there are 3 sessions just on evaluation. So I can't get into too much detail. What do we recommend? These are the AAP recommendations. You know, these are hard enough for adults to follow, but you know, telling a family that their child should not consume more than 2,500 milligrams of sodium per day is not a really practical way of doing things. I still like my old-fashioned approach that don't add any salt to your foods, and kids don't usually do that unless it's a family habit, and try to avoid foods that come in a bag or in a can. Now, it's not always easy as a child because they have less knowledge and less control over how they eat. But generally speaking, families, there's no reason for any family not to pursue some of these habits. We've developed for a long time something called the Big Five, which became the basis of my book. But the Big Five the idea is that even though lots of different habits contribute to obesity in children, a few contribute disproportionately, and they include the frequency of fast food consumption, caloric beverages, not eating together as a family, the lack of habitual physical activity and screen time. We've adopted something in our Fitter Me program as well that's very simple, not to say that adopting our 4 Fitter Me habits will change everything. But if everybody did those things, we would have a lot less obesity. But for individual families that are motivated, this sort of advice might be helpful. Okay, so common scenarios, the last thing we can talk about, and we'll take some questions. So on what you might do. So Alex is a 12-year-old boy with obesity. We have 3 blood pressure readings averaging the 97th percentile. So remember, 95th percentile or higher is hypertensive. We didn't get into this. I will stop here for a moment and tell you that I think within the next 5 to 6 years, so my research career is going to be focused upon 2 things. One is improving how we diagnose common problems in primary care. The other is to really just give up on office-based blood pressure in children and do home-based blood pressure or nocturnal blood pressure. I got interested in this about 5 years ago. I have a colleague who was originally from Japan and relocated to Duke a few years ago. I gave a Grand Rounds talk in Mississippi, I think in 2014 or 2015. And Dan Jones, who runs the Jackson Heart study there, was invited me to speak to Yuichiro Yano. And I had one of the most enlightening conversations with Yuichiro. He said, you know, in Japan, we're pretty much giving up on office blood pressures, both in adults and in children. I said, what are you talking about? He goes, no, we're measuring them at night while people sleep. I thought that was really interesting. And I said, Mel, could we do this in kids? He goes, probably will work better in children. And we tried a few things with these machines. So it's pretty easy. A child hopefully brushes their teeth, parent slips the cuff on, presses a button, and very gently at 2, 3, and 4 a.m., the blood pressure cuff inflates and gives you an average reading in the morning. You slip the cuff off, the kid goes to school. They do not need an ABPM, which is a 24-hour monitor, which is more disruptive to their lifestyle. The 3-night protocol that they use in Japan seems to be working very well, at least in adults. Nobody has done this in children yet. Japan is very different than the United States. So some of my pediatric nephrology colleagues are concerned about people returning the machines to the clinic, et cetera. However, we've done this a couple of times. It doesn't seem to be a huge issue. Parents have been pretty responsible about it. So stay tuned. But for the time being, let's say we're relying on office blood pressures. I don't want to get into what systolic load is here, but basically this child is hypertensive and he has some triglycerides which are elevated, which is not unusual because he has obesity and everything else is negative. So the question to this group is, what would you do with him now? Okay, I have Dr. Boyd, start him on a daily exercise regimen. Okay, anybody, any other thoughts? Salt discussion, discuss lifestyle and diet with parents. Okay, all excellent suggestions. So you would have a lifestyle discussion with this family that's pretty similar to the discussion you might have about weight. And you say, you know, I'm really concerned about Alex's blood pressure. You can talk about high blood pressure causing damage in childhood and later on in life as well. Is this something that concerns you as well? Would you like to work on this together? And here are some suggestions to start. I'm trying to read Sonia. What about the use of respirate for some similar form of intentional, deep, slow breathing? Okay, so biofeedback and breathing. Very interesting, good suggestion. 12-year-olds, he's not going to be interested in his hypertension. I guarantee that, right? It's really going to be up to mom and dad or whoever else is involved in his life to look after this. And if he has obesity, even a modest improvement in his weight status may lead to some lifestyle changes. So let's say we institute some lifestyle changes. We encourage him to do it. And the other thing, the component of it is for him to monitor his blood pressure regularly. It does not need to be with a home blood pressure cuff. I mean, gosh, people will come back and say, well, I can't afford a cuff. I don't know where to get one. You can go to Giant Eagle. You can go to other places to have your blood pressure checked. That's fine. The goal is for him to remain below the 95th percentile. But let's say he comes back, it's 3 or 4 months later, and he has to have his school physical, and there's no change in his blood pressure and no change in his weight percentile. What would you guys do next? So we would, of course, you would continue lifestyle changes, but it is time to consider medication at some point. So we've studied this quite often, and in qualitative interviews, et cetera. Actually, we did a study that we just finished and published about pediatricians' intentions and management of high blood pressure in Chicago and in Denver. And they pretty much have the same thoughts. Well, I'm okay with doing the lifestyle changes, but I don't want to start medications on these kids. So they refer people to pediatric nephrology. In a place like Cleveland or Chicago, that's a lot of kids to refer to pediatric nephrology, and there's not a lot of capacity there at all. I can tell you a lot of families that were referred where I was near Evanston, just north of Chicago, to Lurie Children's in downtown Chicago. And these are not families with a lot of means. So they take the L, they take the subway all the way down there. They go to the pediatric nephrology clinic. And the nephrologist said, I really think you ought to do more lifestyle changes. And they come back, and of course, they're very, very angry about it. It's like, well, nothing happened. So ECHO, for pediatric hypertension really is about starting medication. Sometimes you have to do that. There is no point in checking the blood pressure on and on and on year after year without instituting treatment, hoping that an adult provider takes over and takes that challenge on. It's not an easy decision to start medications. Many folks will be hesitant to take them, but the promise is that, if he does achieve a healthier weight, and if the medications, if his blood pressure remains normal, you can start to taper off as well. So in this case, what we found was there was no change in his BMI percentile, no sustained engagement in lifestyle changes, but his blood pressure was normal. And one can hope that as he becomes more mature, as he starts to take things seriously, maybe he himself, as he's an adolescent, will be able to better control his blood pressure. So we have a comment from Anissa in Cincinnati. We have Cincinnati Children's, which is an outstanding center, of course. We refer to cardiology, which is reasonable. There's no monopoly on this domain. So the grant that we've just submitted to ARC, it's a resubmission. Our medical director is Dr. Carolyn Wilhelm, who is a pediatric cardiologist at Rainbow. So that's certainly a reasonable sort of thing.
In adults, there's the issue of racial differences in starting medications. How effective, is there any racial difference in blood pressure lowering with ACE inhibitors versus calcium channel blockers or diuretics?
It's hard to believe in 2020 we don't know how many kids have high blood pressure. Mm-hmm. It's hard to believe in 2020 we don't know how many kids have high blood pressure. Mm-hmm. We estimate it's between 700,000 and 2 million in the United States. Mm-hmm. Who are those kids? 2/3 are boys. Racially, is there a predilection? Yes, there is. The prevalence overall of high blood pressure in children, according to the new guidelines, is 5.8%. That's very, very high. So if it's 2/3 boys, that means your boys are 8 or 9% of boys are hypertensive. Most of them are undiagnosed. A school study in Chicago looking at African-American adolescent boys, that is the target for hypertension in children. 10 to 15%. 15%, I'm not sure I believe, but I would say 1 out of 10 adolescents, meaning ages 13 to 17, that are African-American. And, we're talking about lower socioeconomic status, but even middle class, I don't think it's going to be that different, have high blood pressure. And we see the same sort of effectiveness of diuretics, probably the preferred choice in this case. Overall, and I wrote in 2016, you want to start with ACE inhibitors. Why? They have the longest track record in children. So all classes of medications have been used in children to lower blood pressure, and they are effective. However, ACE inhibitors consistently have been shown to reverse target organ damage in children as well. And so there are children who have been on them for 9 or 10 years. Ramipril is the original one that was used. But Jackson is absolutely correct. In that target population, you're looking at starting with a diuretic. So, a couple more questions. Is there from Anissa, would you order a renal ultrasound before starting on enalapril? That's a good question. Now, the guidelines for evaluation are somewhat nebulous. So what I said is, if you are going to order something at some point, a renal ultrasound is probably the most useful thing to do. It doesn't mean you cannot start treatment before that. You can start treatment before that. Now, this boy I gave you, he's not African-American in the case, but he's 12 years old. He does have obesity. I think his parents are hypertensive. He's got a lot of risk factors. So it's less likely that he has a secondary cause, but it's a good question. I would order a renal ultrasound on any child in whom I've made a diagnosis of hypertension. Are there any blood pressure meds that are contraindicated? Yes, great question from Sonia. Get this question all the time. I have an adolescent girl who has may be sexually active, may not be all that responsible in communicating to me about things or that compliant. Should I put her on an ACE inhibitor, which are teratogenic? Yes, that's something to consider. If you think that she's on contraception, that she is reliable, that she understands the risks and that her family understands the risks, it's still okay to use ACE inhibitors. We certainly use them on women of reproductive age. But if you have any doubts, I would go with the diuretic in that case. Do you worry about, oh, there was a question right there from Sherry. So that's exactly how I would answer that question. You know, it's just, it's the same sort of thing. You know, who are the children with high blood pressure? Keep that in mind. Mostly boys, but if you do have an adolescent girl who's hypertensive, who may or may not be sexually active, if you have any doubt at all, go with the diuretic. Okay. Great questions. We can move on to our case. Shannon? All right, this is a really interesting case because I think it really brings in the social determinants of health. You know, I tell you, I don't want to get into stories, but I remember a patient I had a few years ago who I had so much trouble controlling her blood pressure and then was prescribing, switching her medications, etc. And then finally she came in one day and the nurse checked her blood pressure, and it was perfectly normal. It was like 110/70 or something like that. And I asked her, well, what are you doing? And this is wonderful. And she goes, I finally started taking the medication that you prescribed for me. So I wonder if adherence is an issue here. But I want to start maybe if Adam is available to comment on this issue of sort of sporadic adherence and how much it has to do with affordability. And if you have any comments, Adam, we appreciate it.
Yeah, I guess I was just curious to maybe ask you a quick clarification about, do you really think that, do you feel she has like a strong, trusting relationship with you?
So the patient established with me in August. So that was our first visit. I mean, it seemed to go okay in terms of provider-patient conversation. And then she did make all of the initial nurse follow-up visits. And then, like I said, she was lost to follow-up and she came back. In the context of the conversation, though, I had to kind of, we're here for you. If there's a reason you can't afford your blood pressure medication, just let me know. So she actually called back the next day to say that she couldn't afford it, not in the actual office visit.
Yeah, so I guess, I mean, it's pretty awesome that I was thinking like, wow, that she was even willing to share it with you, given that this is somebody who's relatively new to your practice. Mm-hmm. I mean, I think that, as you were talking about it, I was just thinking about how much of a challenge it must be for any patient to make a disclosure of having those types of financial difficulties without feeling judged in the care environment. So I think you must be doing all the right things there. I don't know that there's, and I think there are a lot of really positive signals. I don't have any real specific suggestions other than, I think it's a nice example for all of us to keep in mind the need to really have folks' dignity like front and center, especially when they may have a need to disclose that they're having some social or family or financial challenges that are getting in the way of a medication routine, and really just like not thinking about it only as an adherence problem, right? But also thinking about, or like a defect of a person, or right. I think, and I think you're doing a great job here. Just keeping in mind, like this is part of the context of a person trying to live healthier.
Thank you, Adam. I appreciate those comments. I'm wondering, Alicia, if I can't afford the medication is something deeper than the medication itself. So I mean, she's a factory worker, and here in Cleveland, that usually means what, $15 an hour or more. Usually, and sometimes even some, she obviously doesn't have coverage, but I wonder what her financial situation is more broadly. You know, it's great, as I was saying, I can't afford the medications. And if she does trust you, can we probe a little deeper and say, well, what are your financial obligations and responsibilities? Do you have elderly relatives, perhaps, that you have to look after? Or is there some debt that you're in? Or is there something else going on that we need to probe about? Because if that really is going on, then there's more than just I can't afford my antihypertensives. The other thing I would say is you've got a great natural experiment. You've given her the voucher for which is good for a few months, as Sherry asked about. If her blood pressure is under control while she's on the voucher, then you really know that this is a financial issue. If there's no improvement, then I think we've got to explore some other possibilities. So Chris has a question. Did social work also address potential food assistance programs if she is seeing a benefit from medication voucher? That's interesting.
Not based on the social worker's notes that I reviewed, but I think when the patient follows up, I mean, these are things going forward that we can try to definitely implement, because we do have programs with our social workers for food assistance.
Okay, so I wanted to give Jim some time to comment as well about strategies to help this lady, not just in terms of medications, but maybe some other issues of motivation, et cetera.
Yeah, so, you know, whether this is an affordability issue or a motivation issue or a combination of the two, you know, we don't really know quite enough to sort that out yet. But we do know that motivation is always important for adherence, and also health communication about what the patient's condition is and what those risks are downstream is also important. So, you know, and that's a way to also build motivation. If the patient really knows kind of what's in it in the future potentially that this could lead to, that can drive a lot of motivation. So really kind of finding out perhaps on a scale of 0 to 10, how important is it for you to control your blood pressure? And then ask, you know, why did you select that number, a 7 or a 6? Or because of this, or because of that. And it may indicate that either they don't have a good understanding of the downstream implications, or maybe they do. And a lot of times the answer to the importance question is actually the answer to the confidence question and that they'll give you. And that is because I can't afford the medications. I understand the risks, but I just can't afford it. It could be that answer. So it could be a way of a simple way to sort it out a little bit better. What, you know, how important is it for the patient? And then if you don't get any indication about their confidence level, you can move on to that 0 to 10 confidence question, the same question. And between those two questions, you can get a lot of information. And, you know, what you really want is for the patient to really expand upon why it's important at that certain level, how they're confident at another level. And that begins a discussion around those things. So that would be my input.
Thanks, Jim.
In addition to the discount.
Yeah, so I had sent out a list of the $4 formulary from Giant Eagle, and of course there's other pharmacies that do that. And, you know, I've kind of fashioned together an antihypertensive regimen that costs maybe $10 or $12 a month, which should be affordable for most people. That's something to think about. The other issue I would think about is that, okay, you know, the medication is not affordable. Maybe it is used as sporadically as lifestyle changes. Now, before I get to Jackson about the regimen itself, I wanted Chris to maybe talk a little bit about implementing the DASH diet or some other lifestyle approach that might be effective for this lady.
Yeah, and that was why I had asked about the food assistance programs, because as Goutham was mentioning, we really are starting to see some of the social determinants of health aspects playing out. And it wasn't much of the conversation, but my assumption is that if she's having trouble affording medications and she's working within a factory position, some of her access issues, especially at work, are going to be dependent on either vending machines or what she brings with her. So there are opportunities there to kind of plan ahead and think ahead around what are the ways that you can stretch your dollars more and maybe bring food from home and prepare food as opposed to being able to purchase it at work, because most of that will also be high sodium and more processed in that. So some of those kind of simple strategies to help her kind of capitalize on what was it that you wish you could be able to eat at work that you can't, based on kind of your vending opportunities, and then seeing what the food assistance programs might be able to provide in terms of bridging some of those gaps on that financial need. Then maybe that lessens some of that burden to be able to afford the medication.
Mm-hmm. That's a great question that Chris just raised. What would you like to be able to eat that's not available to you? I think that Alicia stumbled upon a huge area. I think I can't afford the medication is probably a gateway to explore her lifestyle and her finances and her family situation in a lot more detail. I don't ask the question of my patients, well, tell me how you spend your money or what are your priorities, but you can ask it in different ways. It goes, well, what are your financial obligations? What are your priorities right now? And how much money do you have left at the end of the month? And what's the food situation like at home to get at food insecurity as well? And there are, of course, validated ways of getting at that too. I appreciate those comments, Chris. So Jackson, Alicia had some questions about the actual pharmacological regimen, including adding a beta blocker. Just want to know your thoughts.
Yeah. She, on the 3-drug regimen that she is on, losartan, amlodipine, hydrochlorothiazide, it actually brought her blood pressure down from the high 180s down to at least the mid 130s. Not quite a goal, but certainly is a dramatic decrease. The affordability issue, I think, is one. She does have the access to the vouchers. $200 in someone on a 5-drug regimen, well, 5-drug regimen that includes atorvastatin, her 3 antihypertensives, and the metformin. She'll go through the $200 fairly quickly. What you can do, though, is, and I've had patients who pay out of pocket. What has been referenced to is the $4 and $10 drug program available through in Cleveland, certainly several of the groceries, but also nationally through CVS, Target. These programs, there are a significant number of medications that are available. And certainly you can get a atenolol and atenolol chlorothalidone combination. That's good doses of both the atenolol, full doses of atenolol and chlorothalidone, a combination. That's $10 for a 3-month supply. So relatively affordable. And you can also add can't get amlodipine or calcium channel blocker that you can use with the atenolol is not available. I think in those programs, I think the verapamil is available. You can't use that with the beta blocker. Calcium channel hydralazine is available, but it's usually in fairly low doses. 25 milligrams is the, which means that for a 100 milligram per day or 50 milligram twice a day regimen, that's about $20. In fact, that's $20 per over a 3-month supply. But you can also, spironolactone's available on that $10 program. So that I've used the regimen that I've typically used when I use that program is the combination of the atenolol, chlorothalidone, 100, there's a 125 regimen, and add to that the spironolactone, which is available on that program. So it gives you a full dose 3-drug regimen, and then the patient only has to pay for only then has to pay for the amlodipine. And that is a 4-drug regimen, very effective with even in patients with resistant hypertension, because that is essentially the regimen for resistant hypertension. You're talking about $20 a month for the 3 drugs, and then pay for the just for the calcium channel blocker or vasodilator.
Alicia, just one thing I tried a couple of times, and there's no evidence for this, but sometimes people will talk about affordability, and Jackson has given you a great scheme for the regimen. But one thing I did is you know, have them go to the pharmacy, get their medication, take it almost in front of me, and then come back later in the day to show them the decrease in blood pressure that can take place if they're on a proper regimen. That can have sometimes a motivating effect on them. And we'll look at this effect. So it doesn't, of course, if the issue truly is affordability, it doesn't address it. However, it helps them maybe make that more of a priority than anything else. It's when a person has knowledge of their cardiovascular risk. So Dr. Raj Gopalan here in Cleveland has a lot of experience with coronary calcium scoring. When you show a patient a picture of their coronary arteries and say, well, this is where your blockages are, and this is why you're very likely to have a heart attack in the next 3 years. Now, and just present that information without any forceful recommendations, with nothing else, it does provide a motivating effect on them as well.
Yeah. Well, the good thing about her is that she's her blood pressure has been close to normal.
Mm-hmm.
It's been demonstrated both in the office, and she sees that it goes up at home. So that's pretty good proof that, and to fairly substantial levels, that's pretty good proof that she needs to be on her medication. And so the challenge is to make it affordable for her. And I think that's a regimen that depending upon now, you know, if she tells you that she can't afford, that we're talking about what the $20 plus the atorvastatin, which she'll probably get on a 3-month supply. But that certainly reduces the amount of funds required on that for the voucher.
Okay, thank you, Jackson. Any final comments or suggestions from the group? Okay, Shannon, back to you.
Thanks, everyone. If you register on our website, Rick has been adding every week's didactic presentation on our Hypertension Spring 2020 page. And the next slide, please. A post-clinic survey has been emailed to you. You have until 5:00 p.m. tomorrow to complete that. Next week, we have a presentation on special populations, the elderly and patients with disabilities. That will be week 10. So we will see you then. Everybody stay safe in the meantime, stay healthy. Hopefully everybody is well for next week.
Thank you, Shannon. Thanks, everyone. See you next week.